Welcome to Unforbidden Truth. I'm Andrew. On this week's episode, I'll be speaking with my good friend Dr. Allie Winters. Dr. Winters and I will be covering topics spanning from mental health disorders, getting mental health treatment during the pandemic, and more. Here's my interview with Dr. Winters. I'm here with my friend Dr. Winters. How are you doing, Doc?
I'm doing great. Thank you for having me, Andrew.
Yeah, thanks for coming on. We've done this a few times, and it's always exciting to talk to you and to get your expertise and opinions on everything.
I agree. I love our chats, and I'm excited about today's topic.
Before we get into it, I want to kick this off with you talking about your credentials and a list of your accomplishments and the type of work you do for that matter.
Sure. I love talking about myself. I graduated from the University of Alabama at Birmingham with my bachelor's in social work, went to the University of Alabama to get my master's in social work, and then the University of Tennessee to get my doctorate in social work. So I'm all about being a social worker and have over 20 years of experience as a social worker, almost 30 actually. But most of my mental health experience has been in the last 15 years or so. And right now I teach, I'm an assistant professor and interim director of social work at Tennessee State University. And I also have a few side gigs as a mental health provider. So that's me in a nutshell.
So you have a lot going on then all the time.
It's the end of the semester, so it's slowing down a little bit, and I'm not unhappy about that.
So today I wanted to basically talk about mental health awareness, and I wanted to cover four mental illnesses, and all the questions are going to basically, follow each disorder. And let's start off with talking about bipolar 1 disorder. Can you break down this disorder?
Yes, yeah. Bipolar is one of the more common diagnoses and can be quite severe. It's characterized by an unstable mood. The mood fluctuates between a high energy or manic phase and a low energy or depressed phase. And these two phases, people will oftentimes vacillate between these two phases. And some, it can be very rapid, like mood can change from one to the other within a single day. And then other people will experience bipolar 1 where they go for long periods of time in one phase or one pole. That's why it's bipolar. In one pole, like say, experiencing significant manic symptoms for weeks or even months. And then they will vacillate to the other side where they experience depressive symptoms for weeks or months. So people's experience of bipolar may be different, but both manic and depressive symptoms have to be present. And that person has to experience this kind of vacillation between the two for a certain period of time to get that diagnosis. Now, manic symptoms can come in a great deal of different severity levels and different types of symptoms. Manic phases are going to be characterized by really high energy symptoms, talking fast, thoughts bouncing around, almost unrealistic, elated kind of mood where you feel invincible. People oftentimes, demonstrate certain high risk behaviors like speeding or racing a car, going shopping, gambling, these kind of high risk, they'll engage in high risk activities that it can be quite dangerous, especially when somebody is unstable. And then the depressed side, which I think a lot of people are probably more familiar with that side because depression in and of itself, people kind of understand that. Low mood, low energy, significant difficulty just accomplishing even the most minor of tasks sometimes can be extremely difficult when somebody vacillates into that low, depressed mood. And that is characteristic of bipolar 1.
And with bipolar 1, what age group have you noticed that's most affected by it?
I think that a lot of teenagers and younger children have been misdiagnosed with bipolar. I think that their symptoms are not quite where they need to be. Outside of kind of seeing this as more of an adult mental illness, I think that you oftentimes see bipolar emerging, in the early to mid 20s and maybe even late 20s. You're going to see that emerge, but you can see that onset as early as in late teens.
What are some basic coping skills that one can implement in their life to make the diagnosis of bipolar 1, better in their everyday life?
Excellent question. Bipolar 1 is very difficult to manage without medication. There has to be some opportunities to stabilize that mood. It is a constant struggle. I'm not saying that it can't be done, but I think that especially when bipolar 1 is so severe, especially when there's some psychotic symptoms that can emerge with bipolar as well. When you're dealing with pretty severe cases, medication, a mood stabilizer, an antipsychotic, certain antidepressants can also be effective. Medication and being consistent with taking medication, not trying to bounce from one medicine to another is another coping strategy. But just generally speaking, I think the first thing that I would recommend in terms of a coping skill for anyone who has a diagnosis of bipolar 1 is to learn as much as you can about your symptoms and the nature of those symptoms. If you can identify when you might be transitioning, say, into a manic state, then you can put in place certain safeguards where it doesn't get too bad, or you have a certain plan in place that you can execute when you're experiencing more severe symptoms. The same would be true for the depression side. If you have a plan in place and you know that, okay, I'm experiencing this symptom and that means it's getting worse. So I need to do X, Y, and Z. So that's my first recommendation is learn as much as you can about your own experience of bipolar 1. And once you do that, then you can really create some solid coping skills to manage your mood on both sides and work with your medication to try to maintain some stability where you don't go super far up and you don't go super far down. And that can take the form of exercising every day, just even taking a walk, getting out into nature and maybe hiking or paddling or doing something that you enjoy that's outside that gets you some of that sunlight, gets your body moving. And that can be especially difficult when people are in a depressed state. But you just try the best you can, right? So exercise, mindfulness is an important part, I think, of this in the sense that if you can have this capacity and practice this capacity to be able to come into the present moment and whatever you're experiencing, you're acknowledging and be able to breathe through some of that intensity. And if you do that, like practice it when you really need it, when you're in a heightened arousal state in terms of the manic episodes, you can breathe through that and be able to bring yourself down. With depression, it would work a little differently in the sense that the breathing would help you relax some of the depression symptoms.
What are some common therapies and treatments that go well with bipolar 1 disorder?
Obviously, cognitive behavioral therapy works really well, especially the behavioral side, because much of how to control bipolar 1 is to really work with kind of your behavioral reactions to these changes in mood. Obviously, if you especially for younger folks, working with the family is an important part, but also with adults as well, working within the family structure to engage the family in first understanding what bipolar 1 is, so that they can understand the symptoms that they see in their family member. But also, that is an enormous strength to have, is to have family that can support you and can help you through the rough phases. So kind of working with the family to help would also be advantageous to that. Support is so important. So I would say that both of those, along with medication, would be the best evidence-based models for treating bipolar.
Now let's talk about schizophrenia. Can you break down that disorder?
Sure, schizophrenia is such a difficult disease, and it's the most severe of the mental illnesses. Is characterized by experiences of what we call positive symptoms, which are, hallucinations or delusions that can become, completely. It can take somebody's experience of reality and completely warp it into something else. And it's absolutely a devastating mental illness because of those symptoms. But there's also some other symptoms that you'll see with schizophrenia. You'll see, classic kinds of depressive symptoms, in the sense that you see people with schizophrenia really struggle with kind of social withdrawal, and kind of decreased engagement in activities maybe that they typically enjoy using, but when they destabilize, they don't enjoy those activities. And oftentimes it's because they become very disorganized in their thinking. They don't have a logical thought process, and then their behaviors become somewhat illogical as well, or irrational, and that can really create an impairment, a cognitive impairment, where there's just a lack of understanding and an ability to communicate ideas, or to even think through some of the things that people are experiencing, especially when they become unstable. So that would be kind of an idea of what schizophrenia really looks like in somebody.
And with schizophrenia, what's the earliest age that one can start exhibiting, symptoms and whatnot?
You'll see schizophrenia, emerging in the teen years on, but this is oftentimes you'll see schizophrenia diagnosed later, like in the late 20s, people have a first diagnosis of that. And sometimes into the early 30s, where these symptoms emerge to the point where then somebody seeks help and then they get that diagnosis. So you see the diagnosis a little bit later than, say, bipolar 1 or PTSD or depression.
And what about coping skills with schizophrenia?
Schizophrenia, because it's pretty much steals people's understanding of reality, which is the only way that we're able to really interact with each other as human beings, is if we share the same reality. And so it just pulls people out of that, and the only medication is one of the only ways to manage that effectively. They're really very, I've worked with people with schizophrenia, and the number one thing that they say, because they're really the experts in their own condition, is consistently taking medication, and then also um, understanding. Again, it's about having some insight into when they may be destabilizing, and having people around you that can notice when you are destabilizing. Because then, when people with schizophrenia destabilize, it can be a very dangerous situation for that person in particular, and they have to get help. and they have to get help really quickly in order to get stabilized before they reach a certain point where they start becoming more paranoid and thinking that their medication is really poison. People are trying to poison them or something. Their reality starts splitting like that. And once people get too far destabilized, it really takes more of a kind of an acute hospitalization to get them back to where they need to be. But again, having a plan and having people around you to manage that, to help you manage it and identify when you may be destabilizing. But schizophrenia, because it's so severe, it also steals life skills from people. Just being able to maintain a job or maintain a home or maintain relationships with people. It's very difficult for people with schizophrenia to maintain what a lot of us take for granted. So working with people about how best to, manage employment and manage a home and anywhere from, how do you go grocery shopping and budget your money and how do you cook certain things? Those life skills is probably one of the best coping strategies, I think, for people with schizophrenia to kind of normalize their world and keep tabs on where they are mentally.
So, what about some therapies and treatments to help treat schizophrenia?
Obviously, I keep going back to cognitive behavioral therapy and mostly the behavioral side. Really the skills training for maintaining mood and certain things like setting up schedules. This is when I take my medication. This is when I perform my hygiene, like taking a shower, brushing my teeth. Those kinds of things can be profoundly important with someone who has schizophrenia, to get on some sort of schedule. And that is really a behavioral intervention that you can work with people on. And then having some sort of psychosocial engagement where people are engaging with their families and developing friendships, maybe going to a day treatment center with people who are struggling with schizophrenia just like them. They can engage in group therapy and learn different ways of coping through that. That's Group therapy is really good, I think, for to learn coping skills because as I suggest, they're the experts in their own disorder and they can help each other find different ways to manage that together.
Next, let's talk about post traumatic stress disorder. Can you break down that disorder?
Yes. A lot of people, when they hear post traumatic stress disorder, I think we automatically think about soldiers during wartime or veterans who come back from war and experience these symptoms. And post-traumatic stress disorder was first understood in the context of combat and the effects of combat on soldiers and especially returning soldiers. But we've learned a lot since then. And PTSD can result in any traumatic event. If a person experiences something that's really scary, especially something that was unpredictable, anywhere from a car accident to sexual assault to physical abuse, domestic violence, all these different traumatic experiences could result in PTSD. And the best way that I understand PTSD is that after any kind of traumatic event, if someone really struggles with the symptoms of that event, that they are having trouble recovering and kind of moving forward in a way that that would be normal before that. If they're struggling at all, there may be some post traumatic stress symptoms there. The symptoms can be experienced with like re experiencing symptoms like nightmares, just images of what happened, thoughts that people feel like they can't control. They just kind of drag people back to that place where they experience this trauma and they can't seem to control that to any degree. That's kind of a set of symptoms. Then there's another set where, where people really experience what we call a heightened arousal symptoms, where they're experiencing a lot of anxiety. All of the physical symptoms of anxiety, like you know, racing heart, butterflies, being tensed up, those kinds of symptoms. You also see something called hypervigilance, which is really quite a common symptom of PTSD, where people they may be in like a larger space, especially with a lot of people, and they kind of scan the room constantly because they want to identify the danger. They're feeling uncomfortable, so they scan their environment to see if there's any danger. And these people oftentimes struggle walking in lines or sitting someplace where there are people behind them. So they often will want to sit, like if they go to a restaurant, they may want to sit where the wall is behind them. And this is a pretty common symptom of PTSD within that hyperarousal. Lots of irritability too, you'll see. And then you've also got kind of the cognitive piece of all of that, where the mood is impacted, by thoughts and feelings that create shame and guilt and regret. Thinking about it, maybe dwelling on it. And you'll see those kinds of symptoms, just kind of this cognitive narration, where the topic is really about the traumatic event and when how they behave during that time, or recanting everything that they did, challenging themselves on what happened and maybe even blaming themselves. So you see a lot of these symptoms with post traumatic stress disorder, and it can be quite severe. You can even see people who experience psychotic symptoms. In particular, you might see something called dissociative features, where people actually, when they experience, say, a flashback, they actually believe that they're there. They're back during that event that was traumatizing, and so they break from reality. Or they might remember things, as if they're watching it on TV. As they recall what happened to them, they might feel somewhat separated from that experience, and that can be extremely a traumatic feeling, but it also can be quite dangerous for people, because when they dissociate, they oftentimes lose control and do things or say things that they wouldn't ordinarily do. It's an extremely complex disorder, but those are some of the symptoms that you might see with PTSD.
And of course, there's no real age group affected by it, right? Because you could be 1 years old or 99 years old. If something happens to you, you could, carry that with you the rest of your life. And
Oh, absolutely. Some of the worst trauma that you can see is with someone who experienced a trauma, what we call a pre-verbal trauma. So prior to, say, 18 months of age, if someone experienced a traumatic event that early in their life, it can have a profound effect on someone's success in life, most definitely. And it's directly related to that post traumatic stress response, because it is also it affects people neurologically, like in the brain. It causes people's brains to develop in different ways or to change structurally if it occurs later on in life. So, yes, there is no age limit to trauma. Therefore, there's no age limit to PTSD. It just would be very difficult to diagnose PTSD until a certain age, I think.
so somebody can at least speak and tell you what's going on.
Right, right. But there's some really great screens and clinical assessments that are used to diagnose even very young, like 3, 4, 5, 6 years old, that kind of stuff. That you can even there's some great screens out there for that.
So what are some coping skills that one can implement to help live with PTSD and make it not so miserable or, have it
Yeah.
better, some days than others?
Yeah. Yeah. I feel like I just start with the same thing, which is get to know your symptoms. You know, get to know your symptoms and take each one, find a coping strategy for it. That is my number one suggestion with PTSD, because each one of those symptoms are actually changing the brain neurologically. And once you start taking control of that symptom, you start reinforcing more positive pathways in the brain that will lead to better coping over time. So, for example, if you're experiencing a lot of hyperarousal, where you're a lot of anxiety, irritability, just discomfort in certain situations, really putting in place a coping strategy that helps you come down, bring your heart rate down, slow your breathing down, relax those muscles, get to a point where you can control that anxiety instead of that anxiety controlling you. And this takes practice every day, really working through how, and everybody's coping strategy, it would be different for their particular anxiety or their arousal symptoms, right? It could be different for everyone, but really focus on each one of these symptoms. If you're experiencing flashbacks, you're going to have an indication of when that's going to happen. It just doesn't happen, boom, all of a sudden. There are indicators that you are either dissociating or that you're a little unstable. So that because triggers, flashbacks can be triggered and sometimes without warning, but people can experience a trigger in different ways. And so if there's a trigger and somebody experiences a flashback and then they start working on recognizing the signs when they're most likely to have a flashback and implement kind of proactive measures to manage that, then that same trigger might not trigger a flashback anymore over time. But it really is about taking a look at each one of those symptoms and working to try to find a coping strategy that manages that symptom effectively.
So what about some therapies and treatments for that, for PTSD?
There's two different general types of evidence-based practice models to treat PTSD. And they fall in either present focused or exposure based therapies. Now, present focused takes a look, and sometimes these are combined. Let me put it that way. The present focused piece is really going to say, okay, you've got PTSD. We can't do anything to change it. So let's go ahead and focus on developing a way to manage this effectively right here, right now, and moving forward. And the present focused is not at all interested in going backwards in time, but exposure based therapeutic interventions are interested in developing those skills at the very beginning, like being present focused at the beginning to develop those skills, and then going back in time to the traumatic event and working with you on, okay, what happened? What happened during this traumatic event? And that is the exposure piece, like you're exposing someone to a traumatic memory. All right. And that can actually increase symptoms temporarily. So that's why you put in place some significant coping strategies at the very beginning before you even go to the traumatic event itself so that they can tolerate that increase in symptoms. But as you're doing that, what you're doing is you're identifying cognitive schemas and ideas and things that we tell ourselves. They're called distortions in the way that we view reality. For example, if you were taking someone back to a traumatic event of, say, childhood sexual abuse, and it was perhaps a recurring event in their life, and what you would really be trying to find is what they tell themselves about the event, like I'm worthless, or this is my only value is to be some sort of sexual plaything for this cohort of people that what this person who's abusing me represents. And so you're really looking for that cognitive piece to come out, and then reframing that, having a conversation about it, making sure that you find some resolution within that process, and that that exposure releases much of the memory. And when you do that, it becomes less threatening. It becomes less uncomfortable when you might be reminded of it, or when you might have nightmares. This traumatic event might not stimulate nightmares as much because you've kind of taken the sting out of it. And that is partly, there's an exposure based therapy called prolonged exposure. And that's really actually the technique is to help people kind of become used to those memories, and be able to tolerate those memories in a way that allows them to move forward, and not so plagued with just these terrible thoughts and feelings attached to them. It just kind of takes the barbs off, and that can be extremely effective. Both are extremely effective, but I think when you add exposure based, you get more long term benefits in terms of treatment. But present focus can be profoundly effective as well, especially for people who, say, have those pre-verbal experiences. They're not going to be able to talk about those. You may have known they happen, but you might not be able to articulate that. So working on kind of present focus symptoms might be a little bit more effective for, say, that population, or others that it would be inappropriate to dive into their traumatic history.
So last but not least, I want to talk about major depression, and I feel like this is probably a more common one among people, and I've had to deal with it, half my life, so I know a little bit about it. Can you break down the disorder of major depression?
You bring up a good point. And I appreciate you sharing that about yourself, because the only way to overcome the stigma is to talk about it. And that takes people who have struggled with it. So thank you for. I know that takes a lot of courage to be able to say I've struggled with this. Major depression is one of the most common of the severe mental illnesses. Major depression impacts anybody. It doesn't matter who you are, how rich you are, how good of a job you have, or anything like that. It is a equal opportunity mental illness, and it can be devastating. Major depression, people experience major depression in a variety of different ways, but some of the symptoms that are kind of characteristic of major depression is obviously having some experiences of depression, low mood, difficulty even getting out of bed sometimes is characteristic of major depression. Difficulty concentrating. One of the things, and I don't think that we talk too much about this symptom, but I think it's extremely common with people who experience major depression, and that is something called anhedonia. And the anhedonia is such a tough common symptom of depression, and that is, I used to enjoy doing these things, but now that I'm depressed, I find no pleasure in it. It's like you should enjoy doing something, but just even thinking about it, you're like, "Meh." doesn't really even appeal to me anymore. People who used to enjoy going out with their friends, they're like, I don't really want to do that anymore, which kind of leads to another symptom of depression, and that is social withdrawal and isolating yourself. People who are depressed tend to have want to close themselves off from people in their life. And that can be a really dangerous symptom because people, when they are depressed, they're experiencing major depressive symptoms. And then they isolate themselves. So now they don't have the support of the people who really probably want to be there for them. But they don't have that support. They feel like they're out on an island, even though it's kind of a self imposed island. They still feel abandoned or rejected, and they feel very alone, and that can very quickly lead to some pretty significant destabilization, including suicidal ideation and even self-harming behavior and suicide attempts. That's another significant symptom of depression. There are a whole bunch of other ones, but these are kind of the more common ones, along with difficulty concentrating and being able to complete tasks, I think can be very difficult, especially for people who are experiencing this while also trying to maintain employment. And it can be a balancing act, I think, for people when they're struggling with not being able to concentrate and complete tasks. And maybe they're lacking the motivation to do that. Again, that's a symptom of major depression as well. And it can impact every aspect of someone's world. But I have a feeling I'm preaching to the choir here. I think these symptoms might be experienced to you know by most people at certain phases of their life. That these symptoms resonate, like, wow, experienced this during this time. I think that most people have experienced an episode of depression. Whether it meets the criteria for major depression or not, I don't know, but I think most of us have had periods of depression, and sometimes very intense.
When it comes to, developing major depression, it's kind of similar in a sense to PTSD, right? Like you can become depressed as early as a teenager, because I know it started for me when I was a teenager. And
I would say that, if someone is going to experience depression, it can happen at any age. Major depression can happen at any age, as young as, 5, 6. You can see some of these depressive symptoms start to emerge in people who will then develop major depressive disorder and have that as a chronic condition. But I think that you're right that most of the time, the severity of these symptoms are going to emerge as severe in the teenage years if someone is going to have a chronic experience with major depression. Now, and I think that's what we're talking about here is kind of this. These are all chronic conditions. They all have treatments, but none of them can really be cured. They just have to be maintained or managed properly. And so when you think about major depressive disorder, even though people can develop depressive symptoms very young, I think that you're right in the sense that a full-blown experience of major depression is commonly going to, like, the age of onset, is going to occur probably during puberty, that you're gonna see these pretty significant symptoms. And then, people in their 20s might also see an onset or an emergence of more severe symptoms as they go through their 20s. It's not uncommon to have onset of major depression late in life, but it's certainly not as common as in the teenage years and in the early through the 20s.
what are some basic coping skills, some realistic basic coping skills that one can implement to make major depression a little bit easier to deal with? I know that, it's hard to get motivated or even cope when you're depressed because, well, you're depressed. So, sometimes people will say just go for a walk or do this or do that, but if one can't even get out of bed, it's hard to, do any of that.
That's so true. And this goes for any of these diagnoses and any of the coping strategies. It is so easy to sit there and say, just go for a walk, you'll feel better, or go out with your friends, you'll feel better. And that's not an easy thing, whether it's bipolar, schizophrenia, PTSD, or major depression. I mean, that's that's easy to suggest and a hell of a lot harder to follow through with if you're experiencing those symptoms. But I do want to highlight this idea that some of these symptoms breed other symptoms. And if you can find the symptoms that breed other symptoms, and control that central symptom. And a good one would be that isolation. If there's a way to create avenues to become less isolated, then there is a potential to really affect true change because that symptom breeds other symptoms. Isolation does. And that may not necessarily be true for everyone. You really again have to study your own symptoms and see which ones might be a central symptom or a symptom that breeds other symptoms. But if you can control that central symptom or at least find ways to minimize its capacity to breed these other symptoms, then that's what I would suggest. That's the best coping strategy is let's just take isolation, for example. It's easy for me to say, just go out with your friends or go out for a walk or go and do this, go and do that. Maybe it is about taking baby steps. Maybe it is about feeling a connection with somebody, calling them, texting them, maybe just doing some sort of Zoom or Skype session or something like that with somebody that you trust, that you can get just a little bit of engagement, taking these baby steps and working through that. Because the symptoms, there's an ebb and flow to these symptoms too. And they can get severe, but they can also retract and become milder. And oftentimes that has to do with the kind of environmental impacts. Also, I guess I haven't talked about medication for major depression, but we probably should. Antidepressants are the best treatment for major depressive disorder. They have a tendency to make your brain less fuzzy and improve your mood because your brain can actually process it a little bit better. And it has the capacity to help you think clearer and be more rational in your decision making and be able to look at your symptoms with, a certain amount of objectivity and become more focused on, okay, I need to control this. So antidepressants are really good for that, but they do take a while to kick in. So I would recommend working with someone who can monitor you in the first, especially in the first month, because it does have a black box warning for increased suicidal ideation and attempts. But medication and then really hitting those central symptoms to try to mitigate the effects of the disorder on creating these other ancillary kinds of symptoms.
You mentioned the antidepressants, and obviously that's one of the best treatments for major depression, but what types of therapies are beneficial for major depression?
Cognitive behavioral therapy is really good. I tend to lean more on the behavioral side as a mental health provider. So I really like interpersonal psychotherapy, which can take a long time to complete. That's a treatment that can take upwards of 2 to 3 years to complete, but it's highly effective for depression. Also, kind of an offshoot of cognitive behavioral therapy, but really more a behavioral therapy, is acceptance and commitment therapy. That can really help with major depression. It is not necessarily an emerging therapy anymore, It has really developed some solid evidence to support its effectiveness in the treatment of depression. And I am a big fan of acceptance and commitment therapy. And because it really does hone in on the behavioral side of things. And I think that sometimes when people get too caught up in their own thoughts, that it's counterproductive to really engage in a conversation designed to affect change in cognitive narration. Sometimes it's just best to look at the behavior and see what things you can do to manage the symptoms a little bit better. So I would say that those would be the best options in terms of treating depression.
So it's May 2021 now, and the pandemic is, I wouldn't say ending, but it's getting better, and a lot of mental health services are starting to open up more. And of course, in the past almost year and a half, they've been really limited. I tried to set up an appointment just for medication management back in February, and I think they were booked out till like July or August. So now that services are becoming available, and I'm sure mental health has been exacerbated with a lot of people because of the pandemic, the anxiety, depression, so on and so forth. What can people generally, whether it's anxiety, depression, whether it's mild or major, do right now to prepare before actual mental health services, come back and that are 100% available? Because as you know, it's 25, 50% capacity. So a therapist can only see 20 patients a month instead of 40, 50. So there's still people struggling out there. And what would you recommend, just as something basic right now until somebody can get in and to see somebody and take care of what they need to get taken care of?
You bring up such an important point. The state of our mental health care in this country was already bad. Lack of services, lack of resources to help people manage their symptoms and control their mental illness. And then when COVID hit, man, that just devastated mental health services to where pretty much the best you could really get was going to a hospital, a mental health hospital, to get the services that you need, and that's not a good use of our services or resources. But COVID has really done a number with our mental health services, and you make a good point in the sense that we are recovering from that, but there's still a lag in the mental health services to be able to deliver the level of services that they were once providing. So that means that people have to go without, and that can be devastating, especially for someone who has destabilized and they're just trying to get back on track or trying to manage some breakthrough symptoms that are making it difficult for them to function. Some of the coping strategies that I've identified here today is would be excellent coping strategies for people to employ while they're waiting for this. Obviously, get yourself on the list as soon as possible. It's going to take a while for especially psychiatric appointments and basically med management. Medication management is really behind. And I think that's across the country. It's certainly true here in Tennessee. And what you're saying, it's true there in Washington as well. When you're waiting, try to learn as much as you can about your symptoms, explore them, try to figure out different ways to control them. With the exception of schizophrenia, if you've destabilized, then you need to seek an acute appointment. I think some of these uh, other mental illnesses, their coping strategies can work in reducing some of the symptoms, at least to be able to tolerate it until you get help. But with schizophrenia, I think you probably need to be a little bit more proactive about getting medication management. So kick and scream and, you know, try to bang on the doors a little bit to get in there if you've destabilized and have schizophrenia. But some of the other ones, just learn your symptoms, find out what works, Keep working at it until the help arrives, and then you will have developed some skills that will go very nicely with the medication that would also help to control those symptoms, so that you're not having some of those breakthrough symptoms that may impact your life in a way that's unacceptable.
Before we conclude this interview, do you feel there's any pertinent subject matter that we haven't covered yet?
Gosh, there's so much to talk about. Maybe we can leave some for the next time we chat. Uh, but um, but I did want to really highlight that this is Mental Health Month. I'm so glad that you're talking about this. Every time that we talk about mental illness or mental health, we're reducing that stigma, right? So I want everybody who's listening to this to know that there is no shame in having a mental illness. And that stops people from getting help that they need, is because of that shame. And like, I should be stronger, or I should be better and all that kind of stuff. Let it go. Let it go. Do not let that stigma stop you from getting the help that you need. Because if you're struggling, reach out for help. Don't be afraid to do that. You may have to wait a little bit because of COVID and all that, but get some help. Reach out. Even reach out to people, that you can trust that can help you. Maybe they're not mental health professionals, but they can at least support you in that process. Try to find somebody who can do that for you, just to be your person to help you. And don't give up. Don't give up. Don't let yourself go down that road where you start losing hope, because that just leads to nowhere. Don't let yourself do that. Reach out to somebody if that's where you're at, and seek out that help and use the suicide hotline. There are several suicide hotlines. If you're thinking about hurting yourself, call somebody up. I don't care if they're strangers. They're there to help. They're doing that out of the kindness of their heart, and they're there. So use them and talk through whatever is happening with you and get the help that you need.
That was my interview with Dr. Ali Winters. Thank you for listening.